Couple wine.
Ready to go.
On, go.
Oh! Welcome to Wine Down Wednesday!
Welcome.
We got our white wine this time.
Yes.
Last week was red wine.
Yes.
All right.
Okay, keep
Are
going.
we good?
I'll figure it out.
Okay. Today is all about breast implants.
Yes. Implant day.
Someone's talking in my ear.
I
How
heard
did that just
someone talking
happen?
in my ear too.
Are you talking to yourself?
No. I don't hear it anymore. And we're going to continue. So,
Okay.
it is especially helpful after today to talk about implants because we've had so many implant consults
So many today.
I kind of feel like I'm sick of talking about them, but it's very apropos for today.
Yeah, it really
So-
is. It's that time of the year because everybody wants to be bikini ready by summer. And if they think,
Yes.
the minute they think about a bikini, they think about boobs. So we want to kind of dive into where are implants today that are offered out right now because things have changed so much over the last 5
Absolutely.
years. And even within the last year.
Yeah.
Like a major change happened.
Yeah, and I know we've touched briefly on implants in a certain way, but it was kind of implants
It was
versus
so
lift, and
small.
you know,
Yeah.
there's a lot of area to cover here. So it's hard to even know where to start. My consults have become so overwhelming even to me because when I started fresh out of residency, there was saline and silicone.
Right.
That's it.
And then there was just saline.
Before, when I was in training, there
Yeah.
was just
Yeah.
saline.
Yep.
And thankfully, my second year of plastic surgery residency, silicone came out, which is why I waited till second year of residency to get my implants, because I wanted silicone. And now they just keep releasing new, improved versions of implants pretty much
Just
every
to
year.
keep getting better and better and better. So yeah, they don't give up. They don't just say this is what it is. Even if there's nothing wrong with it, they just continue to keep making them better.
Absolutely. Because no matter how safe and good implants get, they're devices and they can always be improved upon.
Right.
So when we're talking about the implants, kind of back
Let's
in
talk about him
the
first.
day, this is the saline implant. That's an empty
So-
silicone shell. So for people who want natural and are afraid of silicone, this still has a silicone shell. It's
Yeah.
just not filled with silicone. It's filled with IV saline, which basically will kind of get absorbed by the body if the
That
implant
is funny because
deflates.
everybody always says that. They're like, well, I don't really want silicone because I don't want silicone in my body.
I can understand where some people are coming from, though, because this is
Right.
a solid silicone shell. It's really not going anywhere or doing anything. And I think the big concern patients had for a long time was, is there going to be runny silicone all over my breast?
Am I
Is
gonna
it going to
get
get into
sick?
my lymph nodes? Is it going to make me sick? So previously, especially the first generation of implants, they were like lava lamps. Super runny, gooey, sticky. It almost reminds me of honey. I've taken out a lot of those
And it's
super
all
old
inside everything.
implants. It is gross and goopy. These days, the silicone has been improved tremendously.
Can I have an old one?
Yep.
So we're going to talk about the old ones first. These are, now I use Allergan implants, so I'm talking Allergan brand names, but these concepts really go across the board for the different implant
Right.
manufacturers. These are what are called classic gel implants, and if you're not talking Allergan, they're called Generation 4 gel.
Right.
This was the gel that they studied when implants were taken off the market and brought back on. And if you could feel these, they're pretty soft. They're nice.
Kind of see them sitting.
And if you look, when Kim and I hold them flat in our hands,
We're going
there's
flat.
a little dimple or divot at the top. This was intentional at the time because they wanted to keep the implant soft. And when you put this on a rounded rib cage,
It
does
pushes
fill
it
out.
out.
The problem is once people's tissue would stretch, and once this implant was in for years and
They
years,
wanted to do that.
they get sad. This is still heavy running
Yeah, so
gel.
kind of this is it at first, and then it goes over time, and this is what happens to the upper part of your breast. It ends up being more flat, and a
then
bubble.
round. So to give people more of that upper pole fullness, one of the things the implant companies did was overfill the implants. So that's where this came in. So instead of this, we've got this, which is slightly more rounded, and it did a great job of maintaining upper pole fullness.
Because if you hold that one up, he's not going anywhere near like
There's
mine's
more
going.
upper pole fullness, but it still over time has a tendency for that gel to want to settle to the bottom.
Right.
So a big excitement came out when these gummy bear implants came out, not just because they're shaped differently, but because look at this gel. It is
The
so
gel.
stiff, it just stays. I feel like Ron Popeil. Set it and forget it. It just stays where you put it. So
But these, we'll dive into these in a minute. 'cause
We will.
Stick with smooth for a minute.
correct. But now we have that same thicker gel in a round smooth implant. And if you look what happens when you tilt these straight up, this older gel, even though this is overfilled, still wants to rush to the bottom. The newer gel stays put and is much more like a solid than a liquid.
Yeah. And if you could actually, if you were here to touch and feel them, you would realize that they are definitely more, not firmer, but just definitely more cohesive on the gel, which overall keeps everything nice and fuller longer than the other ones do. That was the whole point of them. And then the most responsive, the most cohesive one, we don't use that much of.
No, so let me explain a little bit more the differences. So this is the older gel, the classic gel. About 91% of the silicone molecules are cross-linked to other silicone molecules, making them behave as a unit rather than free-moving silicone. This is 94% cohesive. This is 97% cohesive. So there are only little jumps and differences between these. Most patients will notice internally the difference between this implant and this implant. Unless you are extremely thin or really sensitive to the sensation of rippling, most patients are not going to need that strongly a cohesive implant.
Right.
Put this back up here.
Yes.
I can actually let it go like that. Perfect. And you shouldn't slide.
All right. So now back to the gummy bear implant. This is very different conceptually from these because this implant is meant to have tissue grow into it. It's textured. Mm-hmm. So when you put this implant in, the downtime is almost double, especially under the muscle, because you can't have any fluid accumulate around this. You can't have it shifting around or it won't stick in the right position. So many people
come in and they're like, oh my gosh, I heard about the gummy. It's the best thing since sliced bread. I need it. So
it's good for some patients. So the positive things about this are because it grows into the tissue, it can stick in place and keep its position over several years better. But if it's placed too high in surgery or if something happens during recovery where it sticks in the wrong position, it can kind of be a nightmare to fix.
Right.
And people want a natural look with this implant, but it takes about 6 to 12 months to get a natural feel.
We had that patient on Monday, remember? And she had these, but they never settled, so they were like all the way up here.
Yes.
And she was like, I just wanted a natural slope, and now I have this bulk of boob up here and nothing down here because they didn't settle or they were placed too high.
And I told her most likely the surgeon just placed them too high and too far in on the chest, and that's okay with these implants because they generally settle. These don't generally settle any lower on the chest.
Right.
These are also linked with something called ALCL. That's been in the news a lot. I don't know how many patients are really aware of it, but it's a form of lymphoma that they've found in around 400 women that have had textured implants at some time in their past. It's still being studied. The FDA is not calling for removal of these implants or recalls or not putting them in. But for patients who don't want that in the back of their mind...
I'm glad you talk about it, too.
A smooth round implant's a better choice.
A lot of people will be like, well, it's not really that popular. It doesn't happen that much, so we just won't even talk about it in the consult. And I just think that in order to make a decision like something like this, you're putting something in your body, you really should know everything that's out there.
Yeah. We've had so many women that come in and have implants from within the last 5 or 10 years. What size is it? I don't know.
Nobody
is it silicone or saline? I don't know. Is it under or over the muscle? I don't know.
Yeah.
So I like to make sure patients understand as much as possible about what they're signing up for when we do surgery.
Absolutely. Absolutely.
So
they tend to be the longer consults too. Because it's just so much education on the devices and on everything that's out there as an option for everybody.
Absolutely. So some of the reasons we also wouldn't want to use this implant, we saw a patient with it today. Yep. This is supposed to sit on your rib cage and face forward. Some people have rib cages that slant to the side. This will emphasize kind of that pointer sister out to the side look if you've already got that going on.
Yeah.
If you've got one side of your rib cage that sticks out more than the other,
the boob will look more like it's sticking out.
Less forgiving for that. So I tend to talk those patients more about using smooth round implants because they are a little more forgiving for it.
And styles
and profiles and sizes. So,
and then we'll go into talking about little boobies.
Yes,
because these are the cutest little things ever.
Yes. So it's kind of funny. Since I started practice, it's been about 10 years. The style of breast has changed
dramatically.
We are shifting volume from here to here, and everybody now wants perky little B or C cups, whereas before it was this full double D look. And not that there aren't individuals
the Pamela Anderson
that still want that.
Like
absolutely
whole style.
Absolutely. Yeah. So these days there are still patients that want that.
Yeah.
But more of our patients are coming to downsize their implants, do lifts, and get something smaller. So whereas 10 years ago, this guy was pretty popular, this nice 500cc extra high profile, super round implant.
These guys are more popular.
These are more popular now. A more natural profile that instead of sticking out and being very round is much more natural shaped, or just going for a tinier implant in general.
Yeah.
And of course it depends on the person. People always ask me, what size implants get you to a C cup? Well, it definitely depends on...
It's an equation of what you have to begin with.
How big your rib cage is, and how the implant sits on your chest.
Yeah.
So it's definitely different from person to person.
Yeah, like a lot of people will look online, they're like, well, she started with an A cup. She got a 325 high profile, so that should be for me. Well, not necessarily. She could be 5'2", you're 5'9".
And there's a big difference.
Yeah, big difference. So I think also, talking on that real quick about, you talked about going from bigger to smaller and that kind of style. I guess we could kind of talk about the sizing that we do with patients to kind of find that out.
So I've kind of developed over the years basically a 3-step sizing process. So the first visit, we take measurements. We talked about the breast footprint last week and how important it is for longevity and safety to try to stay within that. So based on breast measurements, we know a range of implants that are going to fit on the chest. Then we have patients try on a sizing system whereby 25 to 50 cc increments.
Could you get me one of the anatomic sizers just so we can kind of show what those
get
look like?
a couple of them so we can kind of compare.
And keep going on that, and then I'll grab those.
So we have patients try on in a sports bra increasingly large sizes.
Like the chicken cutlets.
Not the actual implants, because those don't always show up like they would
like
under the
chicken
muscle.
cutlets from Victoria's Secret.
But yeah, these are anatomically shaped little cutlets.
According to sizes of volume of cc's to the kind of idea of what they would be in a implant.
So it gives me a much better idea of whether someone's looking for a small change or a big change. Some patients, I expect that they're going to like a 250 cc volume, and they just keep going to 450. And other patients, we put the 250 in, and they're like, "Whoa, this is too much."
Yeah. Or they go to do you have like a 100?
Yeah. So by the way, they come as small as about 120. But if you're a large person and your chest is this wide and we put a little 120 in, it's going to look like a little BB. So again, it's all proportional and all relative.
Yeah. You know, they always talk about, oh my gosh, why did I just forget her name? 90210 with her space.
Oh, Tori Spelling.
They always bring up the Tori Spelling. Like, I don't want the gap she has, but that's her anatomy.
So part of it's her anatomy. Mm-hmm. Part of it, I believe for years, Tori Spelling had capsular contracture, which hardened them and her implant and keeps them stiff so you can't really push them together.
Yeah.
And it also looked like hers might have been above the muscle.
Yeah, because you can kind of see the shadowing.
So this is our sizing system. We have everybody use this Genie bra.
The Genie bras.
To kind of hold the implants in place. And then these are the sizing systems that we use from Mentor to just
they even have a nipple.
Yeah. To give us an idea of how much volume somebody's looking for. So that's step 2 of our process.
Yeah, they're all the stackers.
The third step of the process is to review photos with patients. Not so much so I can guarantee what they're going to look like or what they're going after, but I have them bring in a few pictures of breasts they like and a few pictures of breasts they dislike.
That's always my big thing.
Yeah.
Definitely, because you can get so lost in looking before and afters, and you're never going to find yourself. You're never going to, you'll get so lost in it to find something better than to be on Instagram, boob boards on Pinterest, people in bathing suits, people in low plunge dress lines where they like the cleavage or they hate the side boob in a bathing suit. It's a visual.
It is a visual, because some people, I'll ask at the first consult, do you have any preferences about upper pole fullness or side boob or cleavage? And some people have very specific ideas. Other people look at me like a deer in the headlights, like, I have no idea what you're talking about, I just want them bigger. So that's where pictures come in handy, because they don't need to know the lingo and know
remember
the
one
words.
girl who wanted the cute, natural, petite little boobs?
Oh, yeah.
I mean, we were like, okay, 4'10", small little breast, we got this. And she came into her pre-op.
Oh, yeah. She said a natural C cup, and then brought in pictures of...
Where's him? Where'd the big guy go?
Yeah,
like this.
Super double D, crazy, fake looking, and to her, that was a natural C cup.
Yeah,
so that's why I prefer
visuals.
Pictures versus just discussing things.
Right.
So after we have all of that information, my final step is to look at the implant catalog and look at the measurements of the implants, compare those to the breast measurements, compare the volumes to the volumes we liked trying on, and usually we'll come up with a range of sizes that feels appropriate to the patient.
And then the range of sizes goes to the OR for you to do your whole entire...
Intraoperative sizing. Yes. So many surgeons will not size intraoperatively, and I'm not saying there's necessarily anything wrong with that.
Yeah.
But when you've got asymmetry or you're not sure of how the muscular anatomy is internally and what kind of implant can truly fit in someone's chest,
Right.
then it can be helpful to bring the actual silicone implant sizers to the operating room because they're identical to the permanent implants.
Yeah.
That way I can try on different volumes, sit people up, compare side to side, and know that I like the volumes we're putting in
Right.
before we open the permanent
And I think
implant.
it's just cool because, like, a lot of you wouldn't know this because inside of an OR, but you do know this when you're laying at home. If you're laying on your bed with your arms down to your sides, your boobs are one way. When your arms come out to the side, they're
Yeah.
another way. When you sit up, they're another way.
Yeah. So,
So
we do surgery with arms at the sides.
Right.
Because when your arms are out, it gives you a fake perception of where your nipple is, especially during lifts.
they look perky.
They look great until you put your arms down. So we do surgery with the arms down.
Yeah.
And it's subtle little things like that that can actually kind of affect,
Make a difference.
you know, how your result turns
Yeah.
out.
Yep. Absolutely.
So
did we
feel
didn't talk
like
about
I want to
styles.
cut one of these implants open. I want to cut an old implant open, and I want to cut a new implant open. So figure out which implants we could
Oh my
sacrifice,
God, this is
and then
awesome.
find me a pair of scissors.
Are we going to cut a new one? Oh.
No, not the little bitty new ones, just a newer cohesive.
Okay, guys, so the reason we're going to cut one open is because there is a little bit of a difference with the gel from the old ones to the new ones. But understand this, it would take a lot of something to rip your entire shell open of your implant.
Well, let's talk about rupture.
Yeah.
So, my husband is a 14-year-old at heart.
You guys have seen the videos on Facebook.
Some people have. He has driven over these implants with his truck. He has set firecrackers off under them, and they don't rupture. It is much more chronic wear and tear. So these older implants that have this gel that's looser and it can fold and bend, it's like bending a credit card back and forth.
Right.
And it just
It
gets a
gets
weak
worn.
spot. And then if you, God forbid, get in a car accident or get a mammogram, it's just that last final straw in,
Right.
in an already weak place.
Well, and the company also says, I mean, if there's a defect, it was kind of a defect. It was kind of something from the beginning, could be.
Sometimes.
And that's why they do carry a really good warranty
Absolutely.
on the implants. So
Most implant companies nowadays have a lifetime warranty.
on the replacement of the
So I
device.
have a question.
Sure.
Lucia asked if patients under 22 can get silicone
Great
implants.
question.
Great question.
Great question.
Yes, patients under 22 can get silicone implants, but in the U.S. you void your warranty because the FDA didn't technically approve these devices
Because
for
nobody
use in
was in the
patients
case
under
study.
22.
Yeah.
Yeah, it's not that they're not safe for people under 22, but when they did the study, they didn't have enough patients under age 22
Right.
to be able to safely say these work.
It's a great question because a lot of patients will come in and say that. And it's just you have to weigh out what's worth it to you. We have patients who come in and they're like, I'm going to be 22 in 6 months. We're like, wait.
Yeah.
That's kind of crazy. If you're 19 or 20 and you want breast aug, then that's a long time to wait if you really want one.
So in those circumstances, some patients will choose a small, what I call a starter saline, just to get a little volume in there, but not push the envelope. And that just bides you time and is a safe way to make room in the pocket so that you can switch to a
Right.
silicone later on. The other option is just to go ahead and get the implant and understand you're not going to have a warranty.
Yeah, you just don't have
And
the
it doesn't
warranty.
magically activate when you turn 22. You're just kind of done from the start, basically.
Yeah. I hope
So, time to cut some implants. So, first, I'll just cut a little slice in it. Oh, this feels so wrong. So, you can see this gel is
It's a gummy
fairly
bear.
cohesive. This is not. This
No,
is
I'm saying
Yeah,
it's like a
it's-
gummy bear.
in the
you
sense
squeeze
that
and comes
yeah,
back
you
in.
squeeze it comes back in. But this is a little sticky and goopy. So, it's not totally solid. This is the Generation 4 gel. Yeah.
Mess.
And that's what I got in my body right now. Great. All right. So,
What
Now,
new one were you gonna do?
we got to do a cohesive.
Well, I mean, we have a bunch of these minis.
All right, let's do a new cohesive.
Wait, no,
mini.
this is not. This is an SRF.
Oh, so responsive is not cohesive. Oh, that is RF too.
Oh,
These
SRF.
are only one.
No, they're in the
Are
rooms.
these our
Are you
only?
sure?
Yes.
I'll grab you one then.
SCX. Oh, this is a CX. Should I do it? Should I do it? I
go
should.
for it.
All right, so this is the
Explain.
most cohesive gel.
Explain it. Yeah, I mean, just
So
they don't
this,
understand.
Yeah, that was the
That was
Generation
disgusting.
4 gel. And that was the best of the best when I got my... Yeah, that's what it'll do in a boob. It'll stick. This is the Generation 5 gel. And you can see when it comes out, I'm pushing much harder than I did, and it's
Really
not
hard.
wanting to bulge
Yeah,
out.
and it's not.
It's
gonna
not
stick.
nearly as gummy. Even if I'm trying to pull it, it just doesn't want to
come out. And it doesn't even, it even almost like turns into like a little
Feels
oil.
like booger.
It feels like a booger. It feels like a little oil. But understand that your implant is inside of a capsule as well.
Yes.
So it's not like your implant, unless it is in the breast tissue, behind the breast.
Well, it's still in a capsule.
It's still in a
breast
capsule,
tissue.
yeah. Your capsule forms pretty quickly after surgery, which almost consider it like a eggshell, like a little eggshell that starts to develop around the implant. And it would be very hard, unless that capsule is broken, for that to penetrate through an eggshell.
Usually if you just get an isolated tear in the implant and not a tear in the capsule at the same time, which is the more common way that it happens, then
Like
you
a
get...
shatter, like a little gel shatter.
Well,
inside.
if you get a tear in the implant, most of the time the capsule, your own tissue, is still intact, and it just keeps all the gel in there.
Yeah, it, like,
and
just
most
holds
people
it in.
don't even know that their implant's ruptured.
Right.
So now that we've cut these a little bit,
You can cut it solid in
I'm
half.
cutting it solidly in half.
Oh, I love this one.
All right,
Hurts.
Pac-Man.
Go. Pac-Man.
All right, so you can see it
Look,
doesn't want to.
It will not drop out.
All right,
So they are
and
cohesive.
we need to keep these to show people now that I've cut
Yeah,
our implants
that's freaking
open.
awesome. That is really awesome because
So note, I'm
before,
comfortable.
back in the day, if you did this, you guys, with the liquid one, it would just come
Oh,
gushing
the older
out.
generations, it's goopy mess. It's like maple syrup
Ew.
or honey or I don't know
Where are you
what.
going on that one now?
Ooh.
Okay, yeah, you can already see
Ah,
the difference
it's
cutting
very
it.
bad.
It's sticking to my
That's
scissors. and-
disgusting.
Yeah.
I used to have those. Ew.
Shh, I have them now.
So these are considered your style 10, style 15, style 20, low profile, moderate profile, and high profile. That's like what they stand for. So if you have a style 20, 350, those
From
are those.
Allergan or
Yeah.
Trel.
From Allergan, yeah.
Yeah.
And then I have another question.
Sure.
When switching from saline to silicone implants, is there a bigger risk associated with scarring and healing?
No.
Another awesome question.
It is a great question. So in general, we can talk about two types of scarring with surgery. External scars, internal scar,
Yeah.
which is more talking about capsule and capsular contracture. Unfortunately, any repeat surgery you do does carry a slightly increased risk of capsular
Yeah,
contracture.
'cause you're going back
Revision
in.
rates are higher than primary augmentation for sure.
And more expensive,
Yeah, usually.
usually.
A straightforward exchange, though, if you're happy with the look and the feel, you just want silicone instead of saline, and you're not changing the size tremendously, it can take less than an hour in surgery. We open up the incision, we put the implant in. If we don't do any internal dissection, it's almost a risk-free surgery
Right,
with a
right.
very easy recovery.
With the same price as a regular aug.
Yeah. So it is pretty straightforward, and your chances of external scarring usually aren't higher. But it does carry the slightest increase in risk of capsular contracture, especially if we go putting a bigger implant in and scoring the capsule to make room for it.
Right. Or if you're downsizing, then you might have to have a lift. There's so many different factors into what you're trying to achieve from doing an exchange. But yeah, if you're doing a cap con, having some capsular contracture and removing all that stuff, and it just gets a lot more, like
Yeah.
the one patient we had, I mean, she had capsular contracture, hard boobs that were up here, and definitely had a reason and a validation to get them out. But when she did remove them out and all the stuff was done, she had a little tethering on the nipple incision, and it was just
From just taking them out and having the
yeah.
capsules out.
Because it's never it's not as straightforward as the first go around.
Well, and that's one of the reasons I don't like periareolar incisions. Even though when they heal well, they're a fine line at the edge of the areola, I've seen way too many patients lose pigment or have darkening.
Or the tethering.
Or the dreaded tether. When we have tissue and we cut through multiple layers of tissue, skin, fat, muscle, breast tissue, there's 4 layers of tissue
Right.
there. They almost can fuse together at the incision site and cause this permanent pucker that can be really tough to fix. And sometimes you can cut that scar out, but there's only so much areola
Right.
and breast tissue, and especially if you're upsizing,
Yeah.
there's no wiggle room to take
I think
anything out.
a lot of patients don't realize, like, I mean, if you had, I wish I had like a little squishy boob diagram that you could cut through to show how you have to get through a nipple to get to the actual muscle
Oh,
versus
yeah.
going through into the rib underneath the breast. Because patients are always like, well, but this is just so much easier, and then you don't see the scar, but you don't realize you are going through a ton of layers to get to that pectoral muscle.
And either you have to make the incision on the areola and dissect under the skin over the breast tissue till you get to the bottom of the breast, which can cause skin discoloration and can cause some funky
Right.
scarring along the center. Or you cut right through the breast tissue, which I've seen a couple of surgeons do, which increases the risk of infection and capsular contracture because there's bacteria that live in our breast ducts and our nipples,
Yeah.
and cutting through breast tissue is going to expose your implant to more of
And
that.
if your scars don't heal, You gotta look at them every day.
They're right on the front.
They're there every day you look. But yeah, hopefully that answered her question for the revision. But yeah, incisions are peri around the nipple or down underneath the fold. And the ones underneath the fold, once everything settles, the goal is to have that implant kind of fold over and cover, then hide them back up underneath your breast. And those are, I wish we had our little measuring tape. You could show how small they are. Like they're
this
like
big.
that big. And very
4 centimeters, although if they're the new, more cohesive implants and they're bigger than about a 300 or 350, I've been making them 4.5 centimeters. Since the gel is more solid than liquid now, it doesn't squeeze as easily through an incision. Right. And you can get something called gel fracture.
That I had him right here. This one
you did.
But you're not gonna.
You're not gonna see it on camera. We can zoom.
Can I?
Yeah, you can go to both.
Can you see?
There's a little area where it looks a little more
You can see it
translucent. It's
And
almost
a
as
little
if the
fracture
gel has
inside
cracked. And if you put it through too small of an incision, or if you put too much force on the implant, it can crack your gel. It's not necessarily a rupture risk, but it could be,
It could
because the
lead to one
implant
later,
could be more likely
right.
to fold in
It
that
gives
area.
it like a weak area to the implant.
So that's one of the reasons that for textured implants and for really large implants, we use a Keller funnel to put them in.
Mm-hmm.
A Keller funnel basically looks like a big cake icing
It's
bag.
like, yeah, the icing bags.
And you just put the end of it in the incision and squeeze the implant on in.
And it goes bloop.
And they've shown in their studies that it decreases the amount of force and pressure on the implant, so they're much less likely to crack. And it protects the implant from touching the skin and the breast tissue and areas with bacteria on the body.
Right.
So we're a big fan of the funnel.
Back to the exchange thing too as well. We've had a lot of patients who have come in and they, only have had implants in maybe since 2014 or something, and they're just like, well, I've been told I'm supposed to switch these out. So I'm here. Hi. And we're like, well, is anything wrong with them? Do you have any issues, complaints? No. So let's go on to that lovely, good old...
Debunk the 10-year myth.
Yes, there is no 10-year myth.
I think that may have started because if you had a saline implant and you truly wanted to try to catch it before it ruptured, based on the average rupture rate, it was possibly suggested to people, or maybe they did a study on average, people had them replaced every 10 years. These newer implants could be in their 30, 40, 50 years before something goes wrong.
Yeah.
The FDA recommends for silicone implants getting an MRI every couple of years. I'll be honest, I've never gotten an MRI.
I do ultrasounds.
You do ultrasounds. It sometimes shows up on ultrasounds. It sometimes shows up on
gives me peace of
mammogram.
mind.
But that's the thing. Every patient can make that choice.
Exactly.
It's a recommendation by the FDA, not a requirement.
Right.
And it's a cost most insurances are not going to cover.
Yeah.
And if you think you might have a rupture and it's because of a symptom, you may just want to have a surgery to correct that symptom anyway.
Yeah.
But if they're perfectly fine, you don't have any issue with them.
It's not broke, don't fix it.
Yeah. Well, they did a study, more than cute things. They did an actual study on this in our journal. And the first round of patients that followed those recommendations, they found that there were a few false positives and a few false negatives.
Yeah, I remember that. You were talking
So
about.
people where they had a scan, it said your implant's ruptured, and then
And
they
it
went to
wasn't
surgery,
ruptured.
and it was fine.
Right.
So they ended up having surgery for no reason whatsoever. And there were also a handful of patients who had said the implant was intact, and then they ended up having a surgery for another reason,
Right.
and it was ruptured.
Right.
So no test is perfect. So
No.
I leave that up to patients, and I kind of explain the pros and cons.
Yeah.
The advantage of getting an MRI and checking is you may catch a rupture before it has a chance to potentially have a side effect. So let's talk about some of the side effects.
Yeah, I was just going to say, because that I'm one of those people, I'm like, wait, you just said side effects.
Yes.
What does
So
that mean?
if a silicone implant ruptures, most of the time, like we said, your capsule keeps that silicone in place and it doesn't affect your body at all.
Right.
They have shown that if it's ruptured for several years, in some patients, that can convince your body that there's something inflammatory going on, and it can be a trigger for capsular contracture or hardening of your capsule, and it can cause pain.
Yeah.
In some patients, this is even more rare, but in some patients, that gel can actually kind of on a microscopic level bleed through the capsule, or if there's a tear in the capsule, it can ooze through the capsule and contact the breast tissue. That's, I think, why
Okay.
this is important.
So gross.
This versus this is going to clearly make a big difference inside your body if it ruptures. And now I really want to get my implants exchanged.
So, I mean, I just want to make sure we have some time because I definitely want to dive into that too. I want to dive into our scenarios because that's a big thing. People always will be in a room with us and they're like, do you have implants? We're like, yeah. I mean, like, we think it's obvious, but it's not always obvious. But I think diving into why did you get them? Where are you at today about yours and things like that, just to be on a personal note to patients.
So I understand the roller coaster of implant surgery because I've been on it. for 8 years. I have simultaneously at times been in love with them, hate them, want them out, want them bigger, want them smaller. It is a normal thing to keep wanting to do something that's slightly different.
Right.
I got mine because I had really small boobs and I didn't like it. And I felt like I looked like a little boy, and I felt like when I bought dresses, the tops were baggy sometimes, and I bought 2-piece suits and they just didn't fit me right. And so I got silicone implants. I got them before I had kids. So I would.
You had them in residency.
Yes, I had them as a surgical resident, and I was a plastic surgery resident who didn't want other plastic surgeons to know that I had had surgery. So.
And didn't you have the one lady in the OR who was bad mouthing them?
So two kind of stories about that. One is the 3D imaging, and this is why I don't use it.
Yeah.
I had a size picked out in my head, a nice 350 to give me a C cup. Asked for a C cup. Went into the consult. It was a surgeon I did and do still trust greatly. And we did the Vectra 3D system, and the 400s looked amazing, and my husband was there, and they were amazing.
Go bigger, go bigger.
And we went bigger. And although I'm fine with it now, my posture changed, and I felt like a different person for years. Yeah. And I got stretch marks on my breast, and they got saggier, and my dad called me matronly at one point. And it just... I've been on that ride.
Right.
And I do also remember the week I got them done, being in an operating room with an anesthesiologist who was bad-mouthing women who were getting implants and saying, oh, all these women that get implants, they just stick their chests out and they just want everybody to notice. And I'm sitting there in the room a week post-op thinking, you are an asshole, lady. And you're also clueless.
Yeah, I'm sitting in here with some...
But that's the funny thing about implant surgery. For most people, when you get the implants, your muscle squishes it super tight against your chest.
No one's gonna know
The
right
projection
away.
Does not look like you think it's gonna look. I thought I probably had a B cup when I came out of surgery with pointy torpedo nipples. And then a year later, they had settled into F cup breasts, which was a little shocking.
I did the opposite. I did the look down the shirt and go, oh dear God, they're too big.
So yeah, you've had a little more of a story than I have.
Yeah. I got mine done 8 or 9 years ago, I think, originally, and I had 3 kids, and I had some sad boobs. Definitely. They had taken a life from me.
The ones we call deflated.
Yeah, when people come in, they're like, I'm from, the catalogs of National Geographic. I'm like, oh yeah, I can feel you. So, definitely was like, okay, I don't know what to do, but I want to feel, I was 32, and I was like, I should not feel this way. And he just said, let's fill them all the way up, because they're sagging, and we'll just go as big as we can to avoid a lift. And I went in thinking I was going to have like 300, 325 is what we talked about, a little cute B cup, maybe a C cup, and I came out with double D, 450, 475.
Yeah.
Yeah. And they were really big, and I got used to them for the first year or so, and then after that, it was a nightmare because I should have had a lift.
Heavy.
I should have had a lift, and it was avoided because somebody didn't feel like I needed scars on my body. And if I'd been educated then, I would have taken the scars over the result that gave me. Because it led to 3-4 years later going through a 4-hour surgery for Dr. Goldberg to piece my body back together again and put me back to my little boobs that I had before. So just don't do your research, and definitely get multiple opinions, because it could lead you to...
Yeah, and I've been down that rabbit hole before. I've had patients that really don't want scars, and I don't want to put scars on someone who doesn't want them.
I don't care.
But that's the thing. If someone's projecting that onto you and saying, well, I don't want to put scars on your breasts, even though you're okay with it, that's not necessarily doing the best job for you. And even if someone adamantly doesn't want scars, I want to make sure they know where their breasts are going to be sitting and how heavy they're going to be feeling.
Yeah, they go turn into rocks in a sock.
Yeah.
They totally do. Rocks in a sock, and when you lay down, they just want to go... Well,
how do you fix that?
Oh yes, the popcorn technique.
So revision surgery for implants is something we've done a lot more of, and it's kind of cringeworthy and kind of rewarding because it's really complicated and unpredictable, and yet you can make some real changes in women sometimes. So I have a ton of patients who had had surgery years and years and years ago, and when they lay down, their implants just fall into their armpits. Or they're bottomed out, meaning the implant has settled way below their breast fold and below the nipple, and the nipple looks like it's on top of the implant looking at the ceiling. So there is something I learned from a Swedish surgeon that's called the popcorn technique, and it uses heat and cautery when you have an existing capsule, to kind of strengthen that capsule. In my residency, they taught us all kinds of suturing techniques. And the problem with suturing techniques is if you think about the capsule being like a pair of pantyhose, an overly stretched capsule is like a pair of pantyhose that's lost elasticity. You can tighten those with stitching and hem them till the cows come home,
right back.
but they're not going to get more snap and stuff to them.
Yeah.
So with this heat cautery technique, there's a video of it posted online, you can actually watch the tissue just kind of contract before your eyes.
Yeah.
And I've had patients
Will you
maintain
post that
results
one
3 to 4.
I will.
The one we did.
The before and after, and I think we have some in-trap video somewhere.
We do, and it's just so cool. I mean, her boobs were literally out to here, and now they're like in here.
Yeah.
So that's fixed. You can fix that. You're not stuck that way.
Yeah.
There was one more thing, because today I was like, oh God, you should say that during the video, and I forgot what it was. It was really funny at the moment. With the last one we were in.
Was it about the ribcage thing?
No, because we went over that one. We talked last week about implants and lifts. It's going to totally hit me right after we're done with this.
Mm-hmm.
Well, I have another question.
Sure.
It's about what kind of anesthesiologist we use.
Oh.
Whether it's a nurse, whether it's not.
Yes.
or-
Perfect.
So-
That's a good topic.
Yes, and this could be covered every week because it's relevant to really every
Every
kind of
surgery.
surgery we do. So I, at first, when I opened the surgery center, was really adamant about board-certified anesthesiologist. That's who's safest. That's who's best. That's who's doing my anesthesia. And we did that for about a year. And
We still couldn't do that.
we still
We had a
have
choice.
board-certified anesthesiologists that work with our practice,
Mhm.
but I've transitioned to a group of certified registered nurse anesthetists who are all also board-certified in
Right.
anesthesia.
Which is a big deal.
And there's a group of them that has been working in the area doing cosmetic surgery for about 20 years.
Right.
A lot of cosmetic surgeons with their own ambulatory
Almost-
facilities use them.
Tons of them.
And what I found is that they tend to be more comfortable using lighter anesthesia, lighter sedation. So people wake up quicker, they wake up with less nausea, and we haven't paralyzed anybody's muscles or put a breathing tube down for a breast dog in as long as I can remember.
Right. And I guess you can kind of dive into the why don't you want to be paralyzed and have a breathing tube down your throat?
So some people are just freaked out by it in general.
Well, it's like I said it that way.
Yeah.
I'm like, that just sounds awesome.
So giving the paralytics is the highest risk for that malignant hyperthermia. It's not the only medication that can
Right.
do it, but those muscle paralytics are the main culprit for that malignant hyperthermia.
What is malignant hyperthermia?
So it is
Trying to
a
break it down for
condition
everybody.
where it's basically your body can't process the anesthesia and it causes your muscles to tighten up, and instead of relaxing, they just keep firing and firing, and it brings your temperature up and it screws with your metabolism,
Yep.
and it can be very deadly very quickly.
Yeah.
That's where you hear that those people that are just suddenly dying in surgery with no history and no explanation, that could be one of the reasons.
Right.
So I don't like to use paralytics and gas when we don't need
And
to,
it's hard recovery.
because and that's the
It
other
takes you
part.
forever to wake up.
More nausea,
Yes,
more
memory,
lethargy,
You
more
black out for days afterwards.
Yeah, so
Yeah.
most of our patients now get a little nasal cannula of oxygen. We use similar sedation to colonoscopy, just a few things through the IV. And we have had breast dog patients wake up and be ready to leave our surgery center before we could even clean the room for the next
Right.
surgery.
Yeah. And honestly, guys, we are a level C Quad ASF certified surgery center. We are the same as like a hospital outpatient surgery center. If you go to a hospital outpatient surgery center and you're getting like, I had rotator cuff surgery, or you get your tonsils taken out, or you have a colonoscopy, you usually have a nurse anesthetist
Yes,
over
in
you
the
the
room.
entire procedure, because they have a board certified anesthesiologist who's doing circulation rotating through the rooms. So pretty much you're going to have that anyways. You do have the anesthesiologist on staff there, but from what we've had phenomenal experiences.
And there are certain patients who should have surgery
Right.
in a
That's
hospital or another
that's a good one.
facility. If you've got uncontrolled diabetes, first of all, I don't think you should be having cosmetic surgery anyway. But if you've
Too
got,
risky.
difficult to control high blood pressure
Mhm.
or
Heart.
diabetes that is under control but wildly swings, there are certain patients that we do decide to do in the hospital or at a formal center just for those reasons. But the majority of patients we just counsel, and if it doesn't look like you're healthy enough to have surgery in our center, it's kind of a,
Shouldn't
why
have
would you
surgery.
want to put that risk on yourself anyway?
Right,
So
right.
we do have that as an option. I have privileges at North County Surgery Center and
Right.
Jupiter Outpatient Surgery Center and at Jupiter Hospital, but we use them less than I
Less.
thought we would.
Yeah, and I mean, and most people, I was one of those people who would have been like, put me in a hospital, it's the safest place to be. I don't want to be in your surgery center, it's a hospital, it's probably the best. Not necessarily. You
Not
go
for
to a hospital.
cosmetic
No,
surgery.
you go to a hospital when you're sick, and you go to the hospital because you need immediate surgery or you need certain things. But you are in there with a hodgepodge of other people who are sick and who have staph infections and things, and it's just not worth the risk if you're going for just a cosmetic surgery.
Well, and we have a very limited staff. I
Right.
have one circulator,
It's
one
consistency.
first assist, 3 anesthetists that we mainly work with,
Right.
and the same recovery nurse. So it's a very consistent experience.
consistent.
And when I was at surgery centers and hospitals, sometimes I would get the nice nurse. Sometimes I would get the mean nurse. Sometimes I would get the slow nurse. And you can't ever really be in control
Yeah.
of the patient experience that way.
And you have full control over recoveries and everything. So if the person's recovering a little slower, stay and sleep.
Yes.
If you're in a surgery center, get out. That's
Get
usually
out.
what they
It's
do.
5:30. Get
It's
out.
not really that. It's not that kind of treatment.
So
All right. So I think we covered a lot,
I think we did.
and we're ready to go home.
All right. Well, enjoy the rest of your Wednesday,
Thanks,
everyone.
guys, for watching.
Cheers.
Enjoy the rest of your Wednesday. Oh my god, you cut all these open. They're so gross.
But that was so worth it.
That was so cool. Are we off? Are we off?
Yes.
Okay. I was praying to God that this bad boy was not going to come out and start sticking
No!
too.
I know.
Because I was like, oh my god, people are going to be like, no!
Do you think I would have done it if I thought it would?
Well, I mean,
Well, you
now
have to
put your
trust
hand
that
on
what you're
this.
putting in people's bodies.
Yeah.
Beth is here if you would like to.
Okay, have Beth come back. Ew!
Beth!
Guess what? They just made love in it. We just made a new implant. I just made a new implant. They had sex and they made an implant. They're gonna have a new implant baby.